board. All right, Dr. Camp.
All right. Well, thanks again for the opportunity to present. So today we're going to be talking about why mobility matters. So again, I'll just go ahead and ask you to advance to the next slide. No disclosures. So hopefully today you'll get a better understanding of why mobility is an important part of supporting fall prevention. And when I talk about mobility, we want to also think about really the overall promotion of physical activity. And we'll talk about the difference between exercise and even physical activity as well, and how that has a role. And then linking that mobility, most importantly, to what matters most to patients. And I think that helps with both buy-in, but also actual effectiveness in preventing falls. And then as a staff and as providers, we really need to recognize the components that we should be doing to regularly kind of screen our patients for fall risk, and even think about the environment that we have them in as well, and what we could be doing to improve that. And then with that is to also discuss, again, mobility aids, and would love to have some feedback as well from those that are in the facilities with regards to, what they find most effective in supporting mobility as well. Next slide. So mobility definitely is one of the 4 M's in the age-friendly healthcare kind of model. And when we think about mobility, really the other M's are tightly linked. And so I think it's very important when we talk about what matters to patients, that with regards to mobility, that we have some kind of idea of what their patient preferences are. What was their desirable or meaningful activity that they used to engage in and they still want to engage in? Because that may, again, direct how we're going to best support, continuing to support mobility for them in a meaningful way. And then what medications make an impact on mobility? Some can both improve, but others can have an adverse effect. So we know that there's benefits sometimes of pain medication or narcotics, especially after surgery, to allow for pain relief to support mobility. But we also know they have those adverse side effects. So chronic use of that can be more a hindrance. And there are some medications that are directly linked to increasing risk for falls. And those include some medications that are more like anticonvulsants or benzodiazepines, some antidepressants. So again, I think there's appropriate timing for those, but we should be, working again with seeking opportunities to reduce the medications that may be more of a hindrance or to mobility. And I think one of the other ones that I see oftentimes is a consideration maybe for reduction, especially when patients are experiencing pain, or sometimes statin medications. We start to find some adverse effects for myelopathy and muscle weakness and discomfort with walking. So again, when was the benefit outweigh, sort of the risk of the side effects? And then mentation. Definitely has a role with regards to considering the big Ds, the dementia, depression, and delirium. And we know that those all can have an impact. So how well are we screening to have a better understanding? And then so that we can direct our approach. Obviously, mobility can help with overcoming some of those issues, especially with delirium and maybe even with depression. But with dementia, we might need to take a different approach about how we're supporting mobility. And then thinking about, again, just other things that impact mentation with proper sleep. We all know that that affects our ability to concentrate, but it can definitely have a big impact on our mobility as well. So thinking about behavioral issues, stress issues, anxiety issues, and knowing how that influences safe mobility. Next slide. So what is mobility? Oftentimes when we think about it, the first thing we think about is walking. But I would, just caution you to think about other impacts of mobility. So even if we come down to the very basic micro level of joint mobility being in the extremities, but also in the spine. But that mobility is very impactful to support, again, that patient's desired movements, whether they want to continue to be able to dress themselves, whether again through the rib cage, are they able to, effectively have the right postural control, to be able to sit up and eat and have good phonation with talking. It can impact breathing, it can impact swallowing. So, we can't forget those joints that actually support other functions other than walking. Bed mobility is quite important for many of our patients because of that ability to stay independent with getting in and out of bed, also just even for rolling for pressure relief. So, again, how are we supporting the function and the environment to support that? And then transfers, whether that be from the tub or the chair or the car, where are our patients actually having the most challenge with this form of mobility, and what can we do to support that? And then, of course, with walking, but walking includes both on those level surfaces, maybe within the environment, but how well do they manage it when they come to a threshold, when they have to manage over kind of little rougher surfaces, if they're going to go out with family, what do they need to be able to navigate? And then there are some of those patients that maybe are non-ambulatory and they're using some type of mobility device, a wheelchair or scooter or something of that manner. And how well are they able to use that either to self-propel themselves, and do they have the cognitive function to be safe with some of these assistive devices that are supporting their mobility? Next slide. So I quickly share this. I know this doesn't directly link to nursing home care, but why does mobility matter in healthcare? Well, there's a lot of research in this area, and I just wanted to give a quick snapshot because our patients sometimes do go in and out of hospital care, or they may have elective surgeries. So we do find that mobility is very beneficial in recovery, both with elective surgeries, like, for example, an orthopedic surgery, like a post-total knee replacement, when they do have a bout of pneumonia. So with mobility and encouraging early mobility, we see decrease in length of stay in all of these settings. Both recently with COVID and even prior instances where people require intubation in the ICU. We see with earlier mobility, you can actually get them off or wean them off those respiratory support devices much earlier. And of course, we've heard, again, earlier mobility really decreases the risk of developing delirium, but also in recovery. And it's beneficial, and we've talked about before about addressing issues related to depression. And we know with all of these impaired cognitive aspects too, with mentation, that the less active we are, then the more challenges we can have with increasing other risks associated with that decreased activity. And then even in transitions of care, I think the one important thing that they found with this trial with Project Boost was the communication that happened. They would actually, with this paper that I have listed here, what their promotion was getting, physical therapy actually involved early on in the hospital stay to identify patients' mobility status, communicate with the staff, the nursing, the assistants, what that patient needed to be to mobilize safely. And then it was a constant update and a constant communication. And I think that is the one key thing is that can apply across all settings, is that we need to regularly communicate with other persons having impact with residents or patients about what's effective and what's not effective, and in which environments are there more challenges, and maybe which approaches are more effective for patients. And then the last bullet item there, the reason I share that is, of course, the biggest concern about mobility is decreasing fall risk. And that's a concern and interest, again, in all settings. But in these trials and papers, they talked about decreasing that fall risk in the hospital. And one of the, again, findings that they found is oftentimes it's a multifactorial approach. It's really identifying those needs of that patient and getting the right people on board to address those underlying risk factors. And again, communication was key in many of these research outcomes as well, and sharing. All right, next slide. So why does mobility matter for older adults? Most of your patients are going to tell you, or most of your residents are going to tell you, they just want to stay independent. And so sometimes that means, oftentimes as a physical therapist, we're talking about the exercise and the intervention that we do to increase the ability of our patients. But sometimes, again, thinking about the task in the environment, we can also adjust those. So we might improve the environment with using grab bars or suggesting, again, appropriate footwear and things like that. We might provide devices that allow them to modify the way that they get dressed or do activities. Again, making the right suggestions for the mobility assisted device that will support them can depending on the task and the environment, that can assure safety with mobility. And then, of course, knowing what is going to get that patient engaged in both selecting activities and modifying the environment to, again, allow them to be successful, to engage. And I think that's the most important part. And the patient should always be part of that conversation because this is what's going to both motivate them and then also set them up for success. Next slide. So the CDC put together a study toolkit, and this really was designed especially for the clinical aspect, but there has been more initiatives to say, I think the basic foundation of the CDC toolkit can be applied to all settings. They are talking a bit more about providing resources, and they're out there for specifically addressing fall risk reduction in the hospital. There's even a line that's talking about how can pharmacists have a stronger role in reducing fall risk and doing some of the screening. So I provide these two links for you if you're not already familiar to go explore that website, and it can kind of share a lot more information about some tools and resources that maybe you could utilize within your facility as well to kind of implement some fall prevention screening and intervention ideas. Next slide. So their approach, again, the same approach that we do is screen, assess, and intervene. And whether or not, again, that you do it in the exact recommendations, because some of these things are activities that might be being performed with the clinicians or their physicians, but these can also apply even in that clinical setting with your staff. So a lot of times we really want to know, are our patients falling? Do they look unsteady? Are they concerned about falls? Because these three, sort of insights can give us an understanding about, again, taking preventative steps to prevent future falls, but hopefully even prevent a first fall. And so some of the factors that they've suggested that we should assess that are sort of modifiable, especially when we're talking about the patient, is, are there some underlying conditions? We know that there's sometimes a decline in aging with the vestibular system or sensory symptoms, systems, even vision, that can impact, balance. But is that significant enough that it might suggest there's some kind of underlying condition? And if there's especially a significant change, I definitely would suggest, again, recommending an assessment with an appropriate clinician to look for underlying balance or vestibular issues that may have come on. And then in this population, and especially for those living facilities, it's very common that there is a vitamin D deficiency. And although the research has wavered on the benefit of that in reducing risk for falls, we know there is positive impact in reducing fractures if there is a fall. So, I still think vitamin D deficiency is likely in this population, especially if they're not getting outside or maybe nutrition or diet is impacted. And as I mentioned before, we need to be screening for those medications linked to falls and trying to manage and deprescribe when appropriate, or communicate with physicians about your concerns about medications that might be impacting their stability. And watching for signs for postural hypotension. Are patients or residents staying properly hydrated? Are they on medications that might be over-diuresing them? So if you're especially noticing some instability when they make those initial transfers. And vision impairment is common in this population, but are they wearing their corrective eyewear? Is it clean? Is it appropriate? And then unfortunately at this age, we also know that a lot of us are going to bifocals or trifocals, and that can make a little bit more challenge when they're used to looking down, maybe to navigate something, where they're looking through the part of the lens that actually helps them where reading and up close. So that may not actually be helping them with kind of managing or seeing, again, maybe a threshold or a step or edge or curb like they need to. And then, physicians are asked to watch for issues that sort of indicate, again, when cataract surgery is needed, because this can definitely impair vision. And then looking at feet and I will say shoe wear. Patients are often, or clients and residents are often putting shoes on that are easy to slip on and off, but are they appropriate? And then when's the last time? I mean, some of your staff may be assisting patients with bathing, and how do the feet look? How do the nails look? Is this potentially impacting fit or comfort with wear? And then definitely within residents, within the living environment, looking for those hazards that might be present, whether it be wet floors. I think the construction is always taken into consideration, open pathways and things of that sort, but things can always change. And so watching out for those hazards. Next slide. And so I wanted to provide just a little bit, and Jesse, you can even advance a little. I think there's an animation there maybe on this one, but some of the research, again, when we talk about exercise and intervention, the one thing I wanted to bring to light was this is an interesting systematic review that looked at several studies, almost over 100 random controlled trials, because a lot of times we're saying, well, what exercise is best? What kind of classes, what kind of things should we offer within our centers? And we hear a lot about some programs like Tai Chi and dance, and we should get our patients walking more. We should get them involved in strength training and things of that sort. Well, this was a research study that really looked at what were the programs and how were they designed that actually decreased the rate of falls, decreased the risk of actually having a fall. And if a fall did occur, which of those programs were actually more effective in decreasing a fracture risk if they had a fall? So the one thing I want to just kind of highlight are the two that are circled there, because we may have heard this already, but really that they found the outcomes that were best were a multi-component type program that included balance, functional activity, meaning things that worked on gait or transfers or just more functional tasks involved, real life kind of activity, and then strength training. But those that really focused more on the balance and functional training actually had a greater decrease in related fractures with falls, but both were very effective in decreasing the rate and the risk. So the reason I bring this up is that a lot of clients and a lot of good meaning clinicians or family members would say, well, you need to walk more, or you need to do Tai Chi, and all those are great programs, especially for somebody that might be at a higher risk. They might put them at risk for falling, especially recommending a walking program if they're already having some imbalance. So I do think, again, if you are having programs supported it within your facility, really, again, thinking about what are the components of those programs and trying to make it multifactorial, multi-component as much as possible. And then my heart says that patients or residents are going to be more involved if it actually reflects some functional activity that they enjoy doing in their life and regularly do on a day in and day out basis. Next slide. So what this is not a lot new, but basically, again, suggesting if we really want to look at programs that are effective in fall prevention, again, it should be multifactorial. Again, as mentioned, the strength, the balance, and then functional activities that improve mobility and are specific to their task. But the other one I really wanted to kind of hone in a little bit more on was optimizing postural alignment. We're all guilty of that as well. And hopefully just by saying postural alignment, you all checked in a little bit more with your own posture. But postural alignment is really important with older adults because, again, this can make a difference on, again, how well they breathe, how well they eat, how well they're able to engage. It can influence, pain or discomfort, but definitely it has an influence on balance, And it also has an influence on reducing fracture risk, especially when we're talking about posture through the thoracic spine. So make sure that this is also a component of programs that you may have going on, and think about, if it's not, how it can be employed or be a part of those programs. Next slide. So I just wanted to switch over to transfer aids. And this is where you guys might actually have some, strong opinions on what's been helpful, what's not helpful, what's accessible. But when we look at these pictures, this illustrates things all the way from a very dependent transfer to more of an assist type transfer, to maybe equipment that's, nearby a bedside or in a bathroom or something that actually just helps with a patient being more independent, being able to support those transfers. Now, all of these, especially the ones shown, do have some costs associated with it. And from my understanding, sometimes in certain facilities, they're allowing certain devices and not other devices. But I think when we talk about the selection, the important thing to consider is what meets that patient's need and level of ability, but still allows them to be as independent as possible. So in the next slide, we show more mobility type aid devices. And again, a wide selection of available mobility devices, but again, thinking of the person, the task they want to do, and the environment that they are going to do it in may need a different mobility device for each of those considerations. So some of these come with higher costs than others. And so therefore, again, sometimes more decision-making comes into those processes, but knowing when maybe an assisted device is no longer meeting someone's ability, and making that suggestion to consider an alternative mobility device. And besides having that mobility device, is it properly fitted? Are they using it well? And again, do they have the cognitive ability to appropriately use that assisted device? And then on the next slide, I will say that our older adults are, watching TV, and some of them that still have the ability to kind of be part of that decision-making, see these commercials. And I only put these illustrations in because the up walker is becoming more popular. But I tell you, as a physical therapist, when I think about and have utilized this device with patients, there's some concern there. There's a lot of a lot of patients do it, or well-meaning family members get it for them because they think it'll make them stand taller. And that's what the promotion is all about. But because of that point of contact and pressure being higher, when the person removes one hand to reach forward to open a door or grab for something, it can actually cause those devices sometimes to tip and be unsteady. So they also don't provide great support for sitting on. So I just throw that out there. For some people, it may be great. I'm not a big proponent of it. For those that are actually fairly active, but just to have some issues of concern of stability, a lot of times there's appropriateness for hiking poles. When you have patients or residents that don't want to use an assistive device because it makes them look old, sometimes a hiking pole actually makes them feel fit. And so again, it's appropriate selection for the person. Next slide. So I think just the key points just to consider is how does mobility really impact the desired function of the individual? I think as facilities and providers, we really need to make fall prevention a priority and coordinate with making a plan for each individual. And exercise as a single factor to reduce falls is not always effective. So we might need to think a bit again about getting pharmacy involved, getting physicians involved, maybe therapy involved, to really again decide for those patients that have higher risk levels, especially those with neurological or cognitive decline. We may need to really be safe considering what all is needed to address their needs. And so thinking again, strength, balance, posture, mobility, those are all key elements in preventing falls. But making, again, consideration for the environment and assistive aids to really support that individual, especially with their task and the environment, is important. All right, and next. And so I provided some references that maybe, again, could provide you a little more insight, or maybe direction on some considerations on how it applies to your facility. Now I'm going to turn it over to Susie. She's going to talk a little bit more about implementing quality improvement for fall risk screening.
Great. Thanks so much, Dr. Camp. It's great to be here with everyone this morning. As Dr. Camp mentioned, I am going to talk a little bit more about how to improve the risks of falls within our facilities. And so let's go ahead and jump right in. Jesse may be pulling up the slide deck. Okay, great. So on the next slide, we have some objectives. And today, again, we're just going to focus on different ways that we can assess our existing programs, as well as how we can improve our risk for falls. And so this will include identifying approaches to assess residents for falls. We're going to talk about some great tools to investigate ongoing falls, as well as think about how to develop a sustainable fall prevention program. So again, I feel like everything I talk about with you all is I always say it's not easy. This isn't easy. It's been a tricky couple of years. I think there are still some staffing issues that we're all kind of trying to manage through. You know, as you know, between half and about 75% of our residents are falling annually. And that can really result in a decline in terms of quality of life. So just making sure that we're always trying to think about our risk of falls and how we can mitigate that risk. Okay, so here on the screen, you're seeing some information about assessing your falls prevention program. And, you know, like I said, we've all been really busy. I think this is something that we always have to sort of keep our thumb on in terms of managing through falls prevention. So if you're kind of wondering where your organization is in terms of falls prevention, this is a really great tool from AHRQ that you can use to assess your existing program. This is part of the On-Time Falls Prevention Program, and it's really organized in four sections, and you can see those sections here on the screen. Again, this is a great place to start just to see where you are. It may help you identify some opportunities for improvement. You can always share your results with a QAPI team. This tool is pretty easy to use and pretty straightforward. I always try to share things that are sort of quick and easy. I know we don't have a lot of time to sort of spend doing a lot of this stuff. So if you haven't used this or you haven't checked it out, maybe take a second to take a look at it. Okay, so on the next slide, we're going to talk a little bit more and sort of focus in on three areas in our discussion today. So the first one is sort of performing that fall risk assessment, and Dr. Camp mentioned that in sort of her piece of the discussion. So we're going to talk a little bit more about that. We're going to talk about investigating falls, and as well as how to go about developing a sustainable fall prevention program. So again, it's really hard to prevent falls across the board. You know, generally there's not one person with our residents 24/7, 365 days. So again, there are no guarantees if you're standing right next to someone that you can prevent them from falling. So I just kind of like to think about this as, you know, ways that we can reduce the risk of falls and how can we be the best that we can be. So on the next slide, we're going to talk a little bit about fall assessments. And generally the goal here is to complete the risk assessment within 24 hours of admission, as well as with any changes in conditions and or quarterly. So there's a listing here on the screen. These are standardized assessment tools that you can use, or you may have another one that your home uses. So sort of some key things here that we want to make sure we're documenting include gait and balance, making sure that we're evaluating lower extremity strength and documenting that. Making sure that we're reviewing the medications, blood pressure, making sure that we're noting any environmental issues that may be important, as well as any underlying medical conditions. So again, within 24 hours is the goal here, and making sure that we're doing that on every admission. Okay, on the next slide, we're going to talk a little bit about investigating falls. And here again, our goal is to reduce the risk of future falls. So generally after a fall occurs, it's a great idea to initiate a post-fall investigation, at least within 24 hours, if not as soon as possible. So here we want to make sure that we're reevaluating those things that we evaluated in that initial fall risk assessment. We also want to be thinking about any other risk factors that might have contributed to the fall. It might have been a one-off thing that the resident experienced that contributed to the fall, or there may be a trend there to dig a little bit deeper on. So here on the screen on the left, you see a root cause analysis tool. And this is called very simply the 5 whys. It's really easy to do. Just gather the team around. It's great to have a multidisciplinary team involved. This can take you less than 30 minutes. You want to start just by developing a 1-sentence description of the event. And then you simply ask the team why 5 times. Why did this happen? Why did that happen? And through that process, you will sort of be able to identify those key elements or those root causes that may have led to the fall. So this is a great tool, quick, simple, easy to remember. And, you know, like I said, again, it's best to do with a multidisciplinary team. Another great tool that I really love is the post-fall tool, and you'll see an example of this on the screen, and the links are at the bottom of the slide. But this provides you a checklist of items, which I really like because I feel like we're so busy, and it's really nice to start with a list and have sort of a standardized approach to this. So this can really help you to think of things that you may not have thought about otherwise. So again, quick and easy, you can run through it pretty quickly and make sure that you're doing a thorough analysis. Okay, on the next slide, we're going to talk a little bit about another great approach, and this one I love. This is all about holding a huddle after the fall has occurred. And so there's a sample tool here on the slide, and this can look or feel many different ways. But the purpose here is really to have a productive, positive, safe conversation to really understand why the resident fell. And you really want to kind of determine those factors that cause the fall. So this can be just a conversation. There's some really great prompts on this tool that's on the screen as well. Again, you want to do this in a team setting, so interdisciplinary is best. You do want to do it as soon as possible after the fall because the information is fresh. So again, just a great tool, really easy to implement. You can download it from the link that is on the slide. Okay, so on the next slide, we're going to shift and talk a little bit about developing a sustainable fall prevention program. You know, and as we talked about, you can't truly prevent all falls. And so thinking about or developing a sustainable program is really, really important. So here on the screen, you see some sort of simple and straightforward questions. You can start here and ask your team to determine or develop a sustainable plan. And so these questions really include sort of thinking about who will be responsible for any sustainable fall prevention efforts within your organization, how you will continue to monitor fall rates. So this is all about measurement and making sure that we're sort of staying on top of the key elements that we need to stay on top of. You want to think about any additional support that you need in terms of any improvements that you're making. So generally, as you go through this process, you identify areas that that you want to improve, and you just want to make sure that you have the organizational support to make sure that those changes stick. And then finally, just making sure that the results continue and that you're moving forward. So, so again, simple 4 questions that you can sit down, maybe ask your QAPI team or your administrative team these questions, and you can sort of go from there. Okay, let's go ahead and go to the next slide, please. So this is a research page developed by Texas HHS, and it just really provides some best practices as well as some other highlights that can help you in developing or maybe just improving some key elements of your fall risk management program. Super easy to use. If you haven't checked this out yet, this is really a great place to start. Okay, let's go ahead and go to the next slide. Okay, so just in terms of key points, you know, again, we certainly want to focus on reducing the risk of falls within our organization, particularly as we're focusing on patient-centered care and really improving mobility and sort of making sure that our residents are getting to what matters to them. And so, again, a really important component of that is making sure that we're constantly looking at opportunities to reduce the risk of falls. You know, we want to make sure we have a comprehensive and sustainable approach, you know, and again, that starts on the first day of admission and continues throughout. And then finally, we just want to make sure that within our program, we are assessing falls when they happen, and we want to make sure that we're timely in doing that. And again, always constantly thinking about how to mitigate that risk. So like I said, this isn't easy, but it is really important. And I know we have a lot going on, and staffing continues to be a challenge. So always just kind of thinking about how to improve in these spaces and do that as quickly and efficiently is really important. Okay, so I think on the next slide, we have just a few references. All of the tools that I shared today are within these references, so really easy to access. If you have any additional questions, you can always feel free to reach out to me. Otherwise, thanks everybody for listening, and I will go ahead and turn it back over to Susanna and the planning team for additional discussion. Thanks, everybody.